Alison is Professor of Psychiatry at the Institute for Mental and Physical Health and Clinical Translation, Impact, at Deakin University, Emeritus Professor at the University of Manchester, UK, and President of the International Early Psychosis Association. Alison has been researching the early stages of psychotic disorder since 1994 and established the first ever clinical service for people at high risk of developing a psychotic illness in the same year. The instrument she created to assess risk for psychosis, the Comprehensive Assessment of At-Risk Mental States, has been translated into 18 languages and is used throughout the world, both for clinical and research purposes. She also researches the effects of exercise for individuals with psychotic disorders and the physical health of people with serious mental illness. Alison also leads the mental health node of the HeSANDA project. Over to you, Alison.
Thanks a lot, Matthias. And I need to be able to start sharing my slides.
Sorry about that.
It's all right. Let's see if this works. Okay, so just go back to the start. And as you did, so I will do, I'd like to acknowledge the traditional owners of the different lands on which we are currently sitting, and acknowledge the elders past, present and emerging. And you'll see here the Aboriginal and Torres Strait Islander flags. I'm on the lands of the Wurundjeri people here in Melbourne. It's a lovely day. Okay, so I'm going to talk about clinical trial data sharing from a user perspective, and just to give a little bit of history of the of why clinical data sharing is important. So back in the day, in the mid-1940s to early 1970s, antibiotics such as penicillin and streptomycin were incredibly successful at treating diseases. And here is a poster from back in the day, and you can see this is on a rubbish bin, illustrating how fantastic penicillin was. But what this led to was that doctors thought that a drug's efficacy would be obvious if it was just tested on a few hundred patients. And so medical researchers conducted trials using very small data, very small sample sizes. And nothing else apart from penicillin was found to be effective. So they thought there was no treatments to reduce the risk or reduce the damage that occurred to a person's heart after they had a heart attack. And there was subsequently a very high death rate from heart attacks in those days. But the breakthrough came during the mid-1970s by a guy called Richard Peto, who was a statistician. And he realised that something as common as heart disease, a drug that was effective in only a few percentage of cases would still save many thousands of lives. And he reviewed the evidence for what's called a clot-busting drug, streptokinase. And he found there were many studies, all had small sample size, and none of them showed a significant effect. And what he did was he combined these data sets, analysed them together, and when combined, they revealed that there was a 20% reduction in the number of deaths in those who were allocated to streptokinase. So kind of the first ever meta-analysis. And then a definitive trial was conducted, and streptokinase was found to save lives. He then went about setting up a clinical trials unit, collaborated with a cardiologist who gave the whole clinical trials clinical credibility, got the cardiologists on board. And what happened was that streptokinase became really a mainstay of treatment for people following a cardiac a heart attack, an AMI, for many years. So heart muscle and many lives were saved. Now, that would not have been possible were it not for the data sharing and data reuse. So that's all good. So data sharing is good, and it's happening a lot now, right? Well, I will tell you my story from a secondary user case study. So I received funding when I was working in Manchester to conduct study to look at refining our ability to better identify individuals at high risk of developing a psychotic illness. So just to give you some background so that I'm not talking about stuff that you don't know. So as Matthias said in his introduction, we now know that it's possible to identify individuals at high and imminent risk of developing a first episode of psychosis through use of the ultra-high risk criteria. So these criteria, it's not rocket science. We know that age in adolescence and young adulthood is the highest age of risk for developing a first episode of psychosis. So what we did was say, well, prior to a first episode of psychosis, there are typical prodromal features, and proximal to the onset of first episode, we know there are sub-threshold attenuated psychotic symptoms, such as instead of hearing full-blown voices, hearing mumbling. So we said, okay, that might be a risk factor. We also know that some people have brief psychotic symptoms that then resolve. So that's the blips, brief, limited, intermittent psychotic symptoms. And we also know that people with a family history of psychotic disorder or this sort of schizotypal personality disorder, plus a significant decline in their functioning, so not just have a family history, but also show signs of struggling in their role or social functioning. So we know all of these groups do put a person at high risk of developing a first episode of psychosis. So we did prospective studies looking at the trajectory of these groups. And again, here's a meta-analysis, so data sharing. We found that 22% of these ultra-high risk individuals developed a psychotic disorder in 1 year. That's many hundred above what you would expect from the general population. You can see it's 36% after 3 years. So that's a bit of a background to this study, so I'm not just talking in theory. So although we know that these people are at very high risk of psychotic disorder, it's not possible to predict which ultra-high risk individuals will develop a psychotic disorder and which will not, which means that some ultra-high risk individuals are having unnecessary treatment and they're being told that they're at high risk when they may not be, and that services are using costly treatments in people who may not need it. So we need to research and to improve our ability to predict those at risk of psychotic disorder from the ultra-high risk group, develop a prognostic tool, and then be able to stratify people according to risk. And one of the first steps in doing this was to do an evidence synthesis. And what we decided to do in terms of synthesizing the evidence was, rather than do an aggregated meta-analysis, was to do an individual patient data meta-analysis. So this is not just looking at the effect size of previous treatments, but it's actually trying to get people to share their individual patient data so that we could reanalyze it. This is a much more powerful tool than aggregate meta-analysis. So we developed the inclusion criteria. I won't bore you with those, but we allowed both prospective cohort studies as well as randomized treatment trials to be included in the IPD meta-analysis, and said that they had to have at least 12 months follow-up. So we did a literature search, including snowballing, and we contacted authors and data custodians. And this is an actual picture of me during this process. And these are the findings. So you see in red, there's the significant findings. So some interesting things came out of this. Higher age was a risk factor. The sub-threshold psychotic symptoms here, such as disorders of thought content, perceptual abnormalities, and disorganized speech, were high risk factors, as well as poor functioning. And down here, negative symptoms, so lack of drive, lack of motivation, was also a risk factor. So you see this is a forest plot that you would typically generate from a meta-analysis. An interesting negative finding was that neurocognitive variables were not predictive. So processing speed or ability to think quickly, verbal memory, etc. You can see these are here in black as not predictive. And this is the same information, but in a table. And you can see that, again, the red variables are those that are predictive. So a few novel findings actually from this study. One was this is just a close-up of the disorders of thought content forest plot, and you can see that many of these studies had negative findings, but when combined, it was actually quite obvious that that was a positive finding. And if we go back, you can see that there was actually not that much heterogeneity in the disorders of thought content. So it seems like a fairly robust finding, which is from over 3,000 individual patients contributing data to that finding. As I said, some novel findings were that negative symptoms were predictive of psychosis. These have not previously been included in any prognostic models because they haven't been found to be predictive in some aggregate meta-analyses that people ran, but we found them to be a significant predictor in our IPD meta-analysis. And neurocognitive variables not being predictive was also an interesting finding because these have been included in previous models. So there are new insights into the risk of psychosis that we got by data sharing and data reuse. But in terms of new insights into data sharing, most of our time and energy on the study was actually not spent on the analysis, but was spent on contacting and recontacting data custodians, drawing up data use agreements, and that took over a year of just trying to contact people and asking them to share our data, getting agreements about who would be authors and so on. So really one of the major conclusions, apart from our novel findings, was that we needed a better method for data requesting, access, and secure analysis, which leads to the HeSANDA initiative, which I'm sure others are also going to speak about. The HeSANDA stands for Health Studies Australian National Data Asset, and its aim is to improve access to health research data for maximum benefit. And particularly in mental health trials, what we find is that there are many studies with small sample sizes, as Matthias was talking about. It's very hard to do a primary research study, even when you have very broad criteria like person has to have schizophrenia. It's very difficult to recruit participants. You know, we need the cooperation of clinical services. We need people other than the investigators to go and talk to people with schizophrenia about the study. And we then need people with schizophrenia who, of course, have very low motivation. Typically, we need them to actually consent to being in a study and then turn up to the study. And as also others were talking about, another issue is waste of data. So once the primary paper is written, investigators move on. They have to go and get another grant because that's how we justify our existence. There's really not a lot of time to go back and write secondary papers. So the primary paper is written and the data just sits there. So we at Deakin lead the mental health node. It's one of 9 nodes, and we're aiming to get better use of mental health data. This is the sort of messages that we try to tell people about why data sharing is good. It enables efficient use of data. People can do aggregate IPD and network meta-analyses and so on. And you can pull secondary outcomes and exposures that haven't previously been examined in detail. And that's what we were able to do with our IPD. The secondary users, of course, get to do novel research without the need for running a primary study. High impact publications. Meta-analyses are usually much more highly cited than the original studies that contribute to the meta-analysis, much to the chagrin sometimes of the original data generators. Meta-analyses and have a very high impact on health practice and policy, and they can then lead to more funding. But there are benefits for data custodians as well. Data custodians can develop new insights from working with the secondary users. So it's important to get those agreements in place to see if their data custodians and original contributors can work with the secondary users. They will then get, obviously, self-interest is always in there, kicking a publication themselves, and they find that their data impacts on health practice and policy and ultimately improves the lives of those who participated in the studies. So why am I telling you this? Well, we need people. We need people to contribute data. We need people to reuse and reanalyze data. So that's essentially what I wanted to say, is from the perspective of a secondary user, but also I have been a data custodian as well. And here is the Health Data Australia website, which Matthias was demonstrating before, where you can go and search mental health data as well as other data, and have a look at the studies that have previously been done and think of new research questions that can be generated from reuse of data where people have in principle given permission for that to be reused in this way. Thanks.